Welcome, everyone. Excited to have you for our Utah Women's and Newborn Quality Collaborative Telehealth session for opioid and substance use disorder. Today, we are very fortunate to have Audrey Jericho speak to us. I'll just give you her bio. She is an OBGYN and Associate Medical Director of Women's Health at Intermountain Healthcare in Utah. She graduated from Vanderbilt University, then attended Indiana University School of Medicine and completed residency in Columbus, Ohio at Riverside Methodist Hospital. She joined Intermountain Healthcare in 2004 and is thrilled to work with an organization committed to comprehensive women's healthcare and continued movement toward value-based care. Her interest in projects include integrating mental health in the OBGYN setting, improving the screening of pregnant women for substance use disorders, activating screening for intimate partner violence, and becoming a more trauma-informed organization. Service on the Board of Trustees of Utah Domestic Violence Coalition, YWCA Utah, and Intermountain Healthcare allow her to remain optimistic about efforts to improve the health and safety of women across the Intermountain West. She and her family are frequently found outdoors backpacking, cycling, and Nordic skiing. And this being the first day of autumn, we will have some hopefully opportunities to do that sometime soon. And I will, one quick note on Zoom, again, you're able to unmute by clicking on your little microphone, and you also are able to put questions in the chat. So I will turn it over to Audrey.
Great, thank you so much. And I am just so excited to have this much time to speak with you all about this important topic. So I don't always get this much time. I won't take that much time, but at least having time for conversations and questions and discussions, I think is going to be really, really helpful. I don't have any financial relationships to disclose. I always like to start anytime talking about intimate partner violence, just because it is such a common problem. Just reminding people to take care of themselves. It's not always the right time to hear about this topic for everyone, just because it is so common. Many people have witnessed intimate partner violence as children or experienced it personally or had close friends or family members experience it. So this is going to be recorded, so you can always come back to it later. And I will go through resources for folks, but certainly reach out. My contact information is in here if you have any specific questions about resources. And here I always start first slide straight off of the resource that I use most frequently, which is the Utah Domestic Violence Coalition hotline, which is fabulous because it connects people all across our state to local providers of services. So it's open 24/7, and it's great for anyone. It could be survivor of intimate partner violence who's calling. It could be a healthcare provider, social worker, care manager, or someone who's perpetrating violence and is looking to change. So I highly recommend you put this into your phone and have it and use it frequently if you don't already. And I just wanted to start with just a big overview, because I think these two topics together, substance use disorder and intimate partner violence, sort of heavy and weighing on us. And I'm really excited to have some public health folks on the call. I know probably healthcare workers as well. But sometimes, especially in the day and age of COVID and staffing shortages, everybody's overwhelmed with, one more task, one more thing to do. And I don't want this to feel like that, like another task. I would love to just for people to kind of sit back a little bit, absorb the information, have discussions about it, about how we can improve these resources in our communities and the connections of community members impacted by this. Instead of thinking, just resist the urge to go into your brain and figure out how exactly is my workflow going to look and who's going to do what and what's the computer documentation going to look like. And because really what we're talking about and wanting to encourage is very brief, personal, meaningful human interactions between two people. And ultimately, we want to measure ourselves by how well we promote healthy relationships and how well we connect people in unhealthy ones to effective, useful resources. That's really how we want to measure ourselves. So if you're screening to check some regulatory checkbox, and your mind and your heart are not present in that moment, your patient will know within seconds. I mean, we're all patients, have been patients, or parents of patients, relative of patients, and you know that when you're working with a healthcare provider, whether or not they're truly there and present for you. And if this is done correctly, it really will send the message, I care about your health and safety. I'm knowledgeable about this problem, and I know who may be able to help you. And so if we get nothing else out of this, I think even if it's just helping a neighbor, it's going to be useful. So I broke this up into 3 sections. So started out with some data and evidence, and in the middle, we'll talk about how to screen. And then at the end, resources. And I have time set aside after each of those sections so that we can answer questions, have discussions and input. And I see this as just an ongoing work in progress. I've been working in this like 5 to 8 years or so. And I feel like every few months I change it up and improve it, and that the voice of survivors and other people who screen, social workers, other people in our community has been so helpful. So I really hope we have good discussions here. Really, when it comes down to it, I mean, I came to this topic in a very roundabout way. I wasn't in medical school and in residency. We weren't really taught about traumatic stress and the impact on health. We were told what we had to report as far as mandated reporting and documenting, but we really didn't have a good background on how traumatic stress impacts health and what our role is and what we can do. So it wasn't until I was in practice for over a decade and I realized, man, something else is going on with a lot of my patients that I can't figure out. And, you know, it was in screening for mental health disorders, working with social workers and other people in the community that I sort of came to how important becoming a more trauma-informed healthcare organization is. So I just feel like all of our systems really need to look at these major issues that impact healthcare costs and health and well-being of our communities. And substance use disorder and intimate partner violence are just 2 of them. There are others that we need to work on as well. But before we get overwhelmed with all that work we need to do, I like to break it down, like really, as far as intimate partner violence, we need to get comfortable talking about it. So we need to start the conversation. And in healthcare, we're pretty good about that because we talk about a lot of topics that might not be that comfortable, especially in women's health. We need to help our patients and community members understand that unhealthy relationships impact health. And we need to understand what our local resources are and work with our community advocates who are the experts in intimate partner violence. So when you get overwhelmed, this is what I try to break it down to. In the end, this is what we're trying to do to connect patients to resource. And as many of you know, because I think a lot of you work in the substance use world, or at least interact with that issue, there's definitely connection. So intimate partner violence in early adulthood is associated with alcohol, substance, and nicotine use disorders. We know the prevalence of IPV victimization and perpetration are higher in people who have substance use disorders. And alcohol is involved in about half of all domestic violence and is associated with injuries, chronic health problems, physical and mental, and premature death among victims and their children. Many risk factors for IPV have been identified, and those include substance use, adverse childhood experiences, mental health problems, and so forth. Just wanted to take a second to briefly talk about, what we're doing in our clinic. One of the things that we noticed with our patients who are pregnant with substance use disorder is so many women are scared to come in for their prenatal care because they're worried about what's going to happen with that information. Are they going to drug test me? Are they going to call the police? So we have so many patients who just show up and deliver, and they haven't had their prenatal labs and their diabetes screening and their blood pressure monitoring. And really, we want to pull all folks in and get as much prenatal care as possible and take advantage of that time. And so we have put signs in our restrooms at Wasatch OBGYN up in Layton and Ogden, just letting patients know. So these are on all of our restrooms so they can read it. I mean, we try to reinforce it, but we want them to see that, hey, substance use disorders are common, treatment's available. We have confidential free resources available. And the bottom line is we want to help improve your health and your quality of life. We are not going to drug test you without your permission. We do have to report certain things. So we are upfront about that, if child abuse, elder abuse, but we are not going to drug test you without your permission. And so if we have patients who are dealing with substance use disorder, trying to stay sober, we try to be open about them. Look, hey, if you're doing great, things are going well, and you want a drug test, especially for those folks that are already involved with the system with DCFS, we're happy to run a urine drug screen and great, and show, hey, you're going to your meetings, you're trying, that can be helpful. But if you come in and you don't want one, we're not going to do it without your permission. The caveat to that is that when you deliver, your baby can be tested without your permission, just for the health and safety of that baby. So the pediatrician or family medicine doc knows what's going on there. And we found that patients really appreciate that knowledge about what's going to happen. There are many different ways to screen in pregnancy. We use the 4 Ps, so asking about parents' drug use, partner drug use, past drug use, and then over the past month. And they're able to answer yes, no, or prefer not to answer to open up that conversation. And then I couldn't speak about substance use disorder in pregnancy without mentioning childhood sexual abuse, because as I've done more trauma-informed care, screening patients for depression, anxiety, PTSD, it is shocking to me how many of my pregnant patients who use substances, have substance use disorder, have a history of childhood sexual abuse. And you know, I kind of figured that I started asking all my patients, when was the first time you used heroin? When was the first time you used meth? When was the first time, you know, you used marijuana? And it was amazing how many were associated with their self-medication because of their lack of counseling and help around their history of childhood sexual abuse. So I just wrote down some ideas. I just feel like this is one of the most important things that I added. And again, I didn't start this until I was a decade into practice, but it has helped me so much. I just ask all new patients, hey, I give them a framing statement. 1 in 4 women, 1 in 6 men have experienced childhood sexual abuse. Has this ever been a problem for you? And when they say yes, sorry, you didn't deserve that. Thank you for disclosing. And, you know, we do have some resources to help you. It's not a long conversation, actually, because it's just kind of a yes or no question. And so it's not like it overwhelms me in my clinic, but I can at least address it. I can let them know, look, unfortunately, it's a common problem. And more than 90% of the time, the person who is perpetrating the violence is a male family member or trusted family friend. And that alone, letting patients know that, has been so helpful, because so many people are isolated. They feel like they're the only one that were, you know, abused by their brother or father or uncle. And when they realize that, wow, it's that common, that's, you know, they just don't feel quite as alone. I let them know that, you know, the reason I'm asking this is because it is associated with some health problems. It may not affect you at all, but it does put people at higher risk for health problems. And so if you're interested in resources, and some people say, no, you know, I've kind of gotten through it on my own, or I'm good, and that's fine. But if they do want resources, I give them, you know, some of these resources, which our psychologists and social workers have recommended. I need more online stuff because I don't think people read books anymore. But TRC Utah is the Trauma and Resiliency Collaborative of Utah. They have some great information there. And we can share these slides with everyone too. So when we're talking specifically about intimate partner violence, you know, there's the physical and sexual part of it, which most people think of. But there's also the stalking and psychological harm. And these are perpetrated by a current or former intimate partner, and it's a serious and common problem, but the studies and research show it's also a preventable public health problem. And I think, I always just like to emphasize the stalking and psychological harm, because some of our patients who are really in the most danger have never been hit or sexually assaulted necessarily, but they are extremely controlled throughout the day. So, when they're told what to wear, how to look, who they can speak with, they may be GPSed, they may be financially tracked, their social media is tracked, they're threatened, their pets, their kids are threatened. And that can be really, really serious, but people sometimes don't associate it with intimate partner violence because they've never had a black eye, for instance. So I think helping to teach about what a healthy relationship looks like versus an unhealthy one is so important. And one of the tools that I use in my clinic, and I know that busy healthcare providers are not going to have time to use this all the time, but if you think of a patient coming in and being able to speak with a social worker or a care manager, even if it's a telehealth visit, to go through the power and control wheel is so helpful to kind of understand. And this is, survivors have told me that this visual is the one thing that kind of turned the light bulb on of, oh my gosh, my relationship is definitely affecting my health. It's just such a good visual of the red flags of an unhealthy relationship. So if you can imagine someone coming in, a 19-year-old, and she's screened and she says, oh yeah, my boyfriend's kind of controlling. And if we're able to hook her up with a care manager or social worker or other healthcare provider with some knowledge around this, being able to say, hey, look, if you're seeing any of these things, it's impacting your health. So if your partner is putting you down, making you feel bad about yourself, that's toxic to your health long-term. If your partner isolates you, so prevents you from being around healthy friends and family members, that's a red flag. And then a lot of partners will do that, but then they minimize it. So when you say, I really wish you wouldn't yell at me and call me names, they'll flip it and it's always your fault. Well, if you would just listen to me, I wouldn't have to yell at you. It's always back on you. Some partners will use children. Some will use male privilege. I'm the man of the house, so I'm going to make all the decisions. Economic abuse, preventing their partner from going to school, getting a job, accessing bank accounts, using threats, threatening to hurt her, leave her, or kill himself if she leaves, or intimidations by look, actions, gestures, destroying things around. So lots of patients will look at that and their eyes just get really wide. And they're like, oh my gosh, my partner does all those things or half those things. And they just didn't connect it really because they hadn't experienced physical violence. Of course, women can be perpetrators of violence. Women can be victims. This can happen in same gender relationships. This wheel is out of the Duluth model. And when they looked at it, they were studying relationships where men were perpetrating violence against women, hence the pronouns. But I find this to be a very helpful tool. And I think even if you're not using it in a busy hospital setting where you don't have time to go through this every time, just as part of training, I think it's very, very helpful for people to understand the dynamics. Unfortunately, common problem. Oh, go ahead.
I'm sorry to interrupt. I just wanted to let you know that Casey put in the chat that there are different wheels for different populations. So she's just saying LGBTQ+, youth, adolescents, minority, et cetera. So there are other power and control wheels if people are interested. Thanks.
Yes, those are very helpful. And you can just Google them, pull them up under images and download and print them. And yep, I have used those. So 1 in 4 women report experiencing severe IPV in their lifetime. 1 in 10 teens experience dating violence. And in Utah, rates are about 1 in 3 women will experience IPV in their lifetime. This is data from Utah Domestic Violence Coalition from 2010 to 2013, just to give us an idea. At that time, the homicides, nearly half of our homicides were DV related, and most of the perpetrators were male. Firearms were involved in 60% of the cases, and 40% of perpetrators had a criminal domestic violence history already. In 22% of cases, children were either involved or witnessed the homicide. 34, the perpetrators died by suicide. And this is a point of opportunity for us. There was an active protective order in only 2% of the domestic violence homicides. So if we can kind of identify these situations and help connect people to get protective orders, they have shown to decrease violence. As far as the cost, as you can imagine, it impacts healthcare costs. This is a very, very old study from 2005, but and it's cost aggregated over a 3-year period, but I just think it was so well done that I still include it. So the numbers are very low. They're much higher now, obviously, but a never abused woman cost the system almost $5,000. And if you use emotional abuse only, that popped up to almost $7,000. If you include physical violence, $9,200, and then with sexual violence as well, $9,600. So definitely impacts healthcare costs. Dr. Bridget McCaw worked 8 years for Kaiser, activating their screening for intimate partner violence, and she shared this slide with me, which I love because it just gives a really good overview. You know, there are the obvious problems with IPV, including the immediate injuries that we see, and then the mental health issues, substance use disorders, obviously. Lots of things in women's health that are impacting GYN and pregnancy-related issues, increasing risk there. And then I'm very interested in the other conditions and chronic conditions when we look at trying to drive down healthcare costs to a point that people can actually afford healthcare and it's sustainable. A lot of these chronic conditions are connected with abuse, neglect, and assault. So I think we have a big opportunity here. The effects on children are well known. We know kids who witness IPV are at serious risk of physical and mental health problems, and boys who witness IPV against their mothers are 10 times more likely to abuse their female partners. And girls raised in homes with IPV are 6 times more likely to experience sexual assault. About a quarter of women who experience IPV are assaulted during pregnancy, and 40% of those episodes, it was the first episode of violence. So pregnant women certainly are not immune to IPV. We know that violence during pregnancy can result in low birth weight, preterm labor, and miscarriage. So it's something we should be thinking about. And in about 35% of households where the partner is abused, the children are also abused. So I continue to leave this question in my talks, even though it's a terrible question to ask and we shouldn't be asking it at all, but because I asked it for years, because I just didn't get it. Like, why are these people staying? Why aren't they leaving? After working on this for years, it is very clear to me why people are in these situations. And the fear is so real. Even if people are not currently being physically abused, the psychological threats and stalking, financial control are just huge. And in a state where there are many firearms in the homes, the threats with firearms, lots of people are experiencing, you know, their pets, their children themselves being threatened. And definitely a lot of survivors will say, I stayed because I knew if I left, my chance of getting 100% custody of my kids was very, very low. And I just could not bear the thought of having my partner care for my kids when I wasn't there. I just had to be there. Even though I know it was bad, I needed to be there to protect my kids. Financial issues are huge here as far as housing, food, shelter, figuring that complicated piece out. And then also hope for change, right? These relationships often start out incredibly well. People connect, they fall in love. It's like a massive honeymoon. I can't live without you. You're the most wonderful, beautiful thing. You're my everything. And then things slowly start going bad over time with the control, and then later maybe physical and sexual violence. And so there's that hope of trying to get back to that bit where their partner was the person they fell in love with. And so we really need to stop asking that question, why don't they leave? And instead ask, why do people who perpetrate violence do that? This is what we need to figure out as a society and as a community. Why do they do that? Let's hold people accountable to their actions, and look at it from that perspective. If we look at the pandemic between, this data is a little bit old, but it's kind of nice to look at, compared to 2019 and 2020 with the pandemic, the calls increased to crisis lines, helplines, 15% increase in the number of people that needed emergency shelter, 31% increase in case management hours needed, and 36% increase in the lethality assessment protocol referrals from law enforcement. People are always asking me, like, why do some places have higher rates than others of domestic violence? I always have to, I don't know, I'm always looking for studies, and I found this interesting study that looked at over 400,000 women. Whoops, sorry. This study showed that while IPV is prevalent in all cultures and countries, in cultures where norms justify wife beating and male control of female behavior, where those are widely held, these cultures report higher rates of IPV. The good news is that all of these organizations and more recommend screening all women of reproductive age for IPV. And the reason it's only women and it's only reproductive age is just because that's where the studies have been done. We need many more studies of women of different ages and other populations with IPV. But right now, this is the current recommendation, is that we should screen all women of reproductive age for IPV. We know that healthcare intervention matters, that women who speak with their healthcare providers about this issue are 4 times more likely to use an intervention. And most women do not have recurrent abusive relationships. So if they can, identify where they are in that power and control wheel and get help and move on, most women will have really healthy relationships in the future. So I just wanted to stop there and take any questions, comments, or have a discussion about just that information before we move on to screening for IPV and then resources. Anyone have any questions, comments? Is any of this surprising? Is it pretty much what you all know to be true?
There's a comment from Renee in the chat, and I don't know, Renee, if you want to share that live, or do you want me to read it? Either way.
I can unmute and read it. Which one?
Sure.
I've been chatting incessantly.
Go ahead and start. Thank you.
Which one? The last one, maybe?
Sure, whichever one you'd like to share is great. Thank you.
Okay, well, actually, I did 2 back to back. I first witnessed this phenomenon of abused people not wanting to leave their abusive situation when I was in 4th grade. There was a little neighbor girl who I could see, even at the age of 9, was being abused. And I tried very hard to get her to leave. I offered her a place to stay with me, and 9 years old, right? She did not want to leave, which really mystified me, because why would somebody want to stay in that situation? But the bottom line was she loved her parents and she wanted them to love her back. She just wanted the abuse to stop. She didn't want to bust up her family or see her father put in jail. So that kind of dynamic is very delicate. And then the other thing that I said is that those frontline feminists in the 60s used to say that when women are financially dependent on their husbands or boyfriends or fathers, they have very little power in the relationship, and therefore they're far more vulnerable to abuse. But if women have their own money, and because money equals power, then they have a lot more power within the relationship, and that kind of serves to protect them. And the number one way it protects them is because they know they can leave and they won't starve or be homeless.
Yeah, I think your first comment is tough. And as an OBGYN, this is one of the things I really struggled with, is the psychology of this issue. It's not my area of expertise because I'm not a therapist. But understanding that, understanding our own individual roles in this process. So depending on what our background or area of expertise is. And for me, it was really difficult to screen for something I wasn't going to fix, because I'm very used to fixing problems. So, you know, if there's an ectopic pregnancy, I can do surgery and fix that. If you have preeclampsia, I can induce you if you need to. If a baby's not coming out, I can do a C-section, right? This is an issue that really we have to have the right mindset and empower people who are surviving and trust them, give them information and resources, but also trust and respect their decision-making. Obviously, when it's a child, it's different because we're required to report child abuse. But when it's an adult, respecting that decision-making and helping do what we can from our part, and then, you know, respecting their autonomy and their decision-making, and saying, you know, even if you're going to choose to stay, I'm going to be here to support you in any way I can. And that took me a year, if I'm going to be honest. I'm hoping with some of this education, that time frame will shrink, but it took me a while to get there. But it can be very frustrating. And I think, you know, the studies do pan out on that education and financial piece, because that is a huge barrier if you're in a very unhealthy situation, but you don't have a place to go to live and you don't have alternatives. You know, it's just harder.
Great. Thank you, Renee, for sharing. And thanks, Audrey. Marcella has a comment in the chat. I don't know if Marcella, if you want to unmute or if you'd like me to read that.
Hi. I just thought it would, thank you for, I've been multitasking and listening, and I had to stop writing a manuscript. I was like, oh, she's saying really important things. Like, I didn't know that recurrent abusive relationships is not the norm. And I think that's a super important point to make to people, that you're not doomed to this forever. You can come out at the other side of this with a relationship that's actually healthy. And that's an important point for me. Do you know actually the reference for that, or what the percentages are?
Yeah, I will try to go back and get the reference for you. And I think when I'm going through the power and control wheel, it's a good time to review that with folks. That, look, once you see this and know this, when you are say you're dating someone else, when it starts out with that emotional control and isolation, you identify, you know what it is, and you know it's a red flag. It's very confusing, especially for teenage, like younger women. It seems like love, like, I can't live without you. I have to be with you all the time. I don't want you going out with your girlfriends because I want to be with you. I don't want you to be in the same, I don't want you going out to dinner with another person because I just love you so much. I can't be without you. I mean, that seems amazing. Like, wow, you like me that much? That's awesome. Right. But really, that is a sign of control. And so I think part of that education piece is really important for our younger kids, junior high and high school, and maybe even younger, to understand that. But yeah, I will try to get you the reference for that. All right. Well, if there's nothing else, we can move on to screening, and then we'll have another break too. And I'm trying to watch the time here. So one of the things I really like how Dr. Bridget McCaw, and she's an internist, by the way, and previously worked for Kaiser. the things that physicians and APPs are concerned about is, gosh, how do we ask about this? And then what do we do if people say yes? Where are we then? Especially if we have a busy clinic or we're in the hospital and have lots of people to take care of. How can I offer an intervention that's caring, effective, and efficient? Those are the things that providers care about. The patients are worried about, okay, if I disclose, what's going to happen next? Am I going to be judged by these people? And is this really going to help me? Like, why would I disclose this? Because what can they do for me? I got major problems here, and then am I ready for what's going to happen next? And then there have been other studies about patient expectations. And this is what patients who are survivors have said they're looking for. They're looking for healthcare professionals who are compassionate and not going to judge them. They want confidentiality. That's really critical for them. They want people who are going to recognize the complexity of the situation and understand that there's no easy fix here. They want to avoid medicalizing the issue. They don't want to be rushed or hurried, which is always the trick for us in healthcare. How do we do this in a way where it's efficient, but caring and doesn't feel rushed? They want confirmation that the violence is not their fault, listening and feedback, ability to progress at their own pace and not be told what to do, to have that autonomy and shared decision-making, which makes sense because that's kind of what all of us want when we are looking for healthcare for most things. So a critical piece of the screening is the privacy. Patients must be screened alone. This cannot happen with other people, friends, family members, partners in the room. They must be alone. So one of the things at Intermountain we've created is some signage that we can put up at front desks that just show, hey, we respect people's privacy and this is just a part of our visit. And this is, I'll tell you, for 10 years, I did not do this. I often had family members and things. I wasn't routinely screening for IPD, but there were a lot of patients I never really spoke to alone because I didn't separate them. And, you're seeing 25, 35 patients a day. It's hard to figure out how you're going to do that with your flow. But since I started it, it's been revolutionary with my adolescent patients, with substance use disorder, and with IPV. I mean, I have patients I've seen for over 5 years, and I never knew they had an alcohol use disorder because they always came in with family members or partners who didn't know that they didn't want to disclose to that person. But now that I speak with every single patient alone, all my new patients and annual exams, I have that opportunity, and it's been huge. So you have to figure out ways in your workflow to do this. And sometimes you're not going to be able to do it. You're not going to be able to screen every patient, and that's okay. But it has to be the right setting. They have to be alone. Survivors have said they do not want, they don't associate with these terms, abuse, rape, battered, violence. They just don't see themselves in that way. And so they recommend avoiding those terms. Screening could be written or verbal, and it can be done by multiple people. And I'm the only physician in my group that personally, I do a verbal screen with all my patients, but most of my partners and nurse practitioners and PAs have a written screen that the medical assistant provides to patients. So you have flexibility on workflow there. And there are many different ways to screen, and there's a link with the CDC of different ways that you can screen, and also through UpToDate. But I'm just going to go through an example of how we're screening, and this is based on some of the CDC information, but then also focus groups that we've done at Intermountain with survivors of intimate partner violence, how they wanted this to look, and what they think the most effective screening would be. And all of them start with a framing statement. So just putting it out there that, hey, this is a common problem. 1 in 3 women in Utah experience unhealthy relationships. And so since this impacts health and connecting to resource can improve health and decrease violence, this is why we ask everyone about it. So we're not picking and choosing who we're screening. We're just screening everybody. It's really important to give them the disclosure prior to screening. And so social workers are really good at this already. This took me a little bit too, but it's can be very helpful. Just letting them know, look, we're mandated reporters in healthcare. So there are certain things we are required to report by law. So if you are coming in with an injury for treatment for an injury caused by your partner, and you say this person did this to me, we have to report it. If you tell me kids are witnessing or experiencing violence, I have to report that. Or if you tell me you've been threatened with a lethal weapon, so he has a gun, he's threatened to kill me, I have to report that. Other things are not reportable. So, if kids are not witnessing it, you guys get in a fight, your partner punches a hole in the wall, you're kind of nervous about it, but you don't know what to do. We can have a conversation about that and I don't have to call the police. So this is really critical to help people understand where they stand and where this information is going. And then the questions, we go through 3 main questions about their current relationship. So are you called names, put down, and controlled, which addresses the emotional? Are you hit, kicked, shoved, slapped, which addresses the physical? Lots of survivors will say, asking vague questions like, have you ever been emotionally abused? Have you ever been physically abused? They don't really connect with that as much, but being asked, have you been hit, kicked, shoved, a yes or no question that they can just answer yes or no, and they don't have to go into detail about it, is somehow easier for them. Are you in a relationship where you're forced to do things sexually you didn't want to do? Again, the language here was really critical, coming from survivors saying, if you ask, have you been sexually abused? Have you been raped? It's just a different framing than saying, have you been forced to do something sexually you didn't want to do? They can answer yes, no, prefer not to answer, or already addressed with my provider. So that gives them some flexibility in how they answer that question. And then I personally ask all patients, just because patients could have been in a really controlling, violent relationship 5 years ago, but they're in a very healthy one now, but that past experience is still affecting them. They may have some anxiety, some PTSD, some stuff that they want to work through. So we ask, have you ever been in a relationship like this? And then again, they can answer yes, no. It's something I may still be dealing with. So when they say yes, when they say no, this is a great card that you can give, and it's from Futures Without Violence. And it's free. You just have to pay for shipping. So I have the link there. So if you have an office manager or social worker, they can get on that website and order up these cards. And the cards open up, have a ton of information on them about healthy relationships, unhealthy ones, substance use disorder, anxiety, depression, and hotlines and numbers for resources. So you can say, I'm glad you're in a good place now. If you ever have friends or family members, neighbors going through this, here are some resources so people know. And very frequently people will say, oh, my sister's going through this, or my cousin is going through this. When they say yes, just basic, quick, positive messaging. It's not your fault. You don't deserve this. And this is a safe place for free, confidential support. And leaving an unhealthy relationship is a process, not an event. I can't tell you how many people, because I was freaked out about this when I started screening, because I wasn't screening routinely before, and this just isn't a comfort zone of mine. So social workers told me, okay, Audrey, this is what you need to say when they disclose. And I mean, it's just so powerful to be that brief, just saying, this isn't your fault, and I'm glad you came here. How many people will just start crying? Like, wow, I haven't heard that before. And it's just really not that hard. It's really easy to do. Things not to say, just because I've learned this along the way too. Obviously, if it's an emergency, calling 911 is appropriate. Though the vast majority of time, the people that we see within healthcare, within clinics or labor and delivery, it's often not an emergency. We shouldn't tell people to leave now, because the most dangerous time for people in abusive relationships is the first 24 to 72 hours that they leave. So we really want these patients to connect with a domestic violence advocate and develop a safety plan and work on that way. We don't want to imply that leaving is easy. That's something reflexively, a lot of people are like, gosh, he's being a jerk or she's being a jerk. You should just leave. Well, it's complicated. Like we talked about before, with people fall in love, they may have children together, they have financial issues. Just acknowledging, I bet this is really hard for you because this is a complicated issue. Just simply saying that is helpful. Some people will say, well, why don't you do couples counseling? You're having problems in your relationship. This seems smart. Actually, it can make things worse. And if people are in that power and control wheel, really individual counseling is where they should start. And then maybe couples counseling might be appropriate in the future, but not initially. And we should, of course, never say, how about I talk to your partner? This is really dangerous for people. And we need to keep this information confidential and absolutely not do that. And I added this, you should stay for your children's sake, just because so many of my patients say that they stayed in relationships 5 or 10 years longer than they should have because of the pressure to stay married, to not get divorced, and the pressure to keep children with their with both parents. And really the evidence shows us that kids witnessing this do worse mentally and physically. And so helping our patients understand that can be helpful. So with documentation, there's definitely legal benefits to documenting patients' words and quotes. If we need photos, the attorneys will say you really, and law enforcement, you need, some patients will say, yeah, I've been taking photos of bruises and keeping them on my phone, or scratches or cuts or whatever. But if their face isn't in it, it's not as helpful. So trying to include their face in photos is helpful. We want to document in healthcare our referrals, any mandated reporting, and follow-up for the patient. So we have worked with Cerner. And so our screening form right now looks like this, which is pretty easy. So our patients, we can go through the screening, and then just real quick, we have these 4 little areas that we have to fill out. And then if it's a positive screen, we use a confidential note type. And so I just wanted to emphasize, different people are using Epic or Cerner, so there's variation in systems, but the bottom line is we want to make sure that these notes and problems are not going to the patient portal. So if a patient has a very controlling, violent partner, they are likely tracking where they're going, what they're doing, and often partners will say, oh, you said you went to the doctor, I don't believe you, show me the note. We obviously do not want disclosures of intimate partner violence to go to open notes or patient portal. So that can be super helpful for a lot of medical conditions, but not helpful for this one. So just making sure that things are documented in a confidential way that aren't going to go. And the best way is to let the patient know how the information flows and where it goes, and let that patient help guide you in how to do things. I personally do not add intimate partner violence or domestic violence on our problem list or diagnosis list, because through Cerner, all things put on the problem or diagnosis list flow to the patient portal right now. Hopefully we can get that changed, but right now that is the case. And so we don't want a patient going home, checking her cholesterol level with her partner standing right there, and then the partner seeing intimate partner violence or domestic violence on that problem list. There is a way to do it in Epic, I understand, that where it doesn't flow to the patient portal. But so just make sure where your information goes. We want to make sure this information is not appearing in billing, after visit summary, explanation of benefits. We want to protect the patient that way. And obviously, if there are any photos of IPV or sexual assault, to make sure that photos are stored confidentially as well in the chart. So I'm bringing up the danger assessment. This is really more for care managers or social workers, and I would love to have a conversation about this. Jackie Campbell is a nurse who looked at how can we triage domestic violence patients to prevent domestic violence homicide. So what kind of tools do we have? Because in medicine, in so many different ways, when we have patients come in, we triage them. We figure out who's at highest risk, who's at lowest risk, and this is what we're going to do with them. So she has found some tools, and you may have heard of lethality assessment, danger assessment, where you look at domestic violence victims and you ask them a number of questions. So some of our of folks in law enforcement are using this tool, and it's been shown to decrease domestic violence homicide by 30% on the East Coast. Where if they called to a scene of a DV scene, they separate the partners, talk to them individually, and they do a lethality assessment. And it's a series of questions. It's like 15 to 20 questions. And if it's high, then they can say, look, other people in your circumstance have been severely injured or killed. I'm really worried about you. And I suggest, can we get you to shelter? Can we get you to a family member where your partner doesn't know where you are? You know, so it just sort of, it's sort of a red flag alert to help patients understand kind of where they are, that they're at higher risk. And Jackie developed one for healthcare that's just 5 questions. Anyone who's using this really needs to be trained. So this is why I say social work. I have done her training and it's awesome. And I actually use this in my office, but most healthcare providers are not going to use this. This is mainly going to be for social workers and care managers, but it'd be helpful in your systems if you had people who were trained in this. So has the violence increased? Has he ever used a weapon against you or threatened you with a weapon? Do you believe he's capable of killing you? Does he ever try to choke you? And by that, they mean strangle. Is he violently and constantly jealous of you? So people who had these things in common were more likely to be victims of a domestic violence homicide. So I'm really interested in how can we incorporate this eventually into healthcare triage of domestic violence victims. On strangulation or choking, as it's sometimes called, Dr. Kathy Franchek, University of Utah, has done so much great work, and she helped develop a Train the Trainer program through the UDVC work group. And so this information is from some of that. Just knowing strangulation can be fatal without external evidence of injury, and that injury may take hours to develop. 50% of victims of strangulation have no visible injury. And thankfully, due to a lot of activists' work, in 2017, Utah increased the penalty. It used to be a misdemeanor, strangulation was, believe it or not. Now it is a felony. And if you look at non-fatal strangulation, it was reported in 43% of completed homicides and 45% of attempted homicides. So there's a 7 times risk of being a completed homicide. So it's obviously a huge risk factor for future homicide. So it's something important to let people know. You know, if he ever holds you up against the wall by the neck, drags you across the floor by the neck, strangles you, that is a huge red flag that your partner is capable of killing you. There is a protocol through emergency departments, because even though these patients, you know, they may say, yeah, I was strangled, but I feel fine now and I look fine, there's no problem there, they should still be evaluated in the emergency department, because a lot of these patients will need CT angio of the carotid and vertebral arteries because they're at higher risk for stroke, and that can be delayed. So a lot of the EMS, there's a lot of education going on with the EMS folks around this. So I will stop there. That's sort of information on screening, and then we'll move on. The last part is going to go over resources, but I would love to stop there and hear people's comments and questions.
Previously, you had mentioned was the importance of screening privately. And can you talk about the workflow? Like, what are some best practices and how people can do that?
Yeah, so different people are doing different things. And at Intermountain, we're rolling out this screening. And then we have a huddle monthly to talk about what's going well, what can we change, what's working well for certain flows. So I think it really depends on your setting, but I'll give you a couple of examples. I know in labor and delivery at McKay Hospital, the way they're doing it is, and which, by the way, I think it's great to screen on labor and delivery, but it's a pretty terrible place to screen too. When you think about someone coming in labor, their partner is going to be with them. It's an emotional time. It's a physical time. You're about to have a baby. Like, it's not the ideal time to screen someone for this. In my opinion, I think the ideal time is in a clinic setting where you have a known relationship with your provider, you have that trust, you have that time. But that being said, it is important to address this on labor and delivery as well. So the way they're doing it at McKay, and I think it's working pretty well, is the patient comes in and as they're checking the patient in, they'll say, hey, we're going to bring her over here to do her weight and her vitals, and we'll have you wait in the triage room or the labor and delivery room. And so they take the partner over there, they separate them, and then they have the screening right there by the scale, and they take them into a room where there's no one around, and they ask them at that point. And that's been working pretty well on labor and delivery. In a clinic setting, so there are some people like to do it right up front, like, hey, we have a new patient, we're gonna bring her in, and we talk to everybody alone, and we do that right up front. And we ask all those personal questions up front. I personally find that a little awkward, because if you don't have a relationship with that person, you bring them in, sit them down, get their blood pressure, and then you ask them about sexual assault, domestic violence, substance use disorder, STIs, abortion. You're like, what? Like, this is too much. So I personally like to bring the whole family in, or whoever's in there, do what needs to be done on the issue. But at the beginning, I tell everyone, look, at the very beginning, I speak with every patient alone for like 5 minutes, but this is perfect. I'm so glad you're here. You're supporting your partner. But at the end, like the last few minutes, I'll talk to her alone. We go through everything. And then I say, okay, if you'd step out, I always talk to everybody alone. And then that's when I get it. Because then I feel like at least I have some sort of relationship with that person. But there are some people who screen up front and still have some people disclose. I just think that trust is so critical for people to feel comfortable enough.
Great, thank you for sharing that. And then a question in the chat is saying, after you've done the initial confidential screening, how do you work to maintain that confidentiality with office staff, referrals, et cetera?
Yeah, that's a good question, especially as we're trying to roll out social determinants of health. So we're trying to screen for so many different things: food insecurities, housing insecurities, transportation issues. And IPV is a little bit different, because you can't just lump that in because of the safety concerns and the confidentiality concerns. So we are not just lumping that in with our general social determinants of health questions because of those issues. With referrals, I mean, we often will like if I have a patient who discloses in my office, I'll often call on my cell phone, the link line, or, my local shelters are the YCC and Safe Harbor. And the vast majority of patients don't need emergency shelter. Most people just need an advocate, some safety planning, or some group counseling, what have you. But I will call them on speaker with the patient in the room, and we'll set up a time where they can connect. And then there's nothing documented. The only thing I have is in the confidential note type, I will put that they were referred to Safe Harbor or something like that.
Thank you. Any other questions?
Yeah, following up on the last comment, with the pandemic and the lockdown and people, kind of isolated at home with a potentially abusive partner, they may not be able to leave the house and go to screening, go to therapy or anything. Again, how do you maintain the confidentiality? You obviously can't do, telehealth and Zoom checkups when the abusive person might be standing right there behind them.
This has been really hard. I'm doing a lot more televisits. And so I see a lot of people for GYN issues and do tele. And I always ask people at the beginning of the visit, just like an opening, oh, okay, so it looks like you're at home. Who else is at home with you? Just to get an idea of who's in the house with them. And because we don't want to screen when that person is there, and it's hard to tell if people are alone. So I usually try to do, if I'm on a televisit, ask them up front who's at home with them. And so I can get an idea. Oh, are your kids there at home? Is your partner there? What's going on? So I have an idea of who's at home. And some of the resources, I'll get to some chat lines, because there are some chat lines that people can access, which are really helpful for people. But it is an issue because access to healthcare in general has been shut down. That's why I think this information and the education is so critical, so people can help their neighbors, friends, and family members. Because we all have the ability of having this information and distributing the information. All right, well, I'll move on to resources so we can have time at the end. So one of the things, Utah Domestic Violence Coalition prints these, which I love, in Spanish and English. And it's such a great tool to have their link line. We put these up in our restrooms. They're great to have, and it's also such a good visual for your staff, because some people, are thinking, oh, this isn't a problem here. It's not a problem in our area or in our neighborhood. And then you see half those numbers are gone and you're having to replace that sheet frequently. So the visual for staff is really helpful, and you could contact Utah Domestic Violence Coalition and help them pay for shipping, so that they can mail these or drop these off for you. They're really helpful. Like I've said, the most common thing that I use is that link line, just because they can connect you to our different member programs across the state. There's a Stop the Violence website that has a nice map of Utah and has all the different shelters and advocacy programs across the state. So that's a good visual. And then the 211 form, like, if you have a patient and they're being impacted by this issue, we don't want to give them a bunch of handouts, because if they took those home, that could potentially make things worse. Sometimes people will take pictures on their phone if that's safe for them to do, but we have to be careful about phones being tracked now. The small little numbers they can tear off and put in their shoe, sometimes helpful. But I really like the 211 forms for this. If you don't use them already, definitely Google the 211 form, and you can look at resources by county and print it out. And so they have, hospitals, they'll have food banks, libraries, and the DV hotlines. And you could circle libraries and give them that, and they can put it up on their refrigerator at home. And so it's really non-threatening. It's just a generic resource list, but it has that link line on there. So that's very helpful to survivors. That Trauma and Resiliency Collaborative is a great website. I encourage people to check that out and sort of browse through any victims of violence, traumatic stress. There's some really good resources about adverse childhood experience studies in there. And then I added the links to Nevada, Idaho, and Arizona down there. This hotline is the one that I was talking about that has a chat line. So that's, so many younger people just don't use the phone. They're not going to call and speak to a human being. They just don't do that. And that's where the hotline is really helpful, or in someone who's living in a small house or apartment and they really can't get away to call, but they can use that. I'm going to go through the My Plan app in a second. I have a little more information on that. And then I've listed some other websites that are just great. If you have teenagers, loveisrespect.org is a fabulous website where you can take little quizzes about your relationship and whether it's healthy or not. Futures Without Violence has endless resources on this issue, and then included some information on sexual violence, human trafficking. And the Red Flag campaign, that's from the CDC, has a really good printout on healthy versus unhealthy relationships and what that looks like. And I use their handout a lot with patients. But this My Plan app has been awesome. I mean, ultimately, we really want the human being to human being interaction. We want survivors to be talking to advocates who are experts in domestic violence. That's ideally what we want to have happen. But this can be a good tool, and it can be great for, if you're working with a neighbor, friend, family member, coworker who's in a really unhealthy relationship. I encourage you to download it and check it out. It just allows them to look at look at their risks, help make safety plans, learn about the support that's around them. And don't forget what's reportable. So vulnerable adults, child abuse, threats with lethal weapon, and treating assaultive injury. These are all reportable events. But if I'm seeing someone for an annual exam and she comes in, she has some bruises that are suspicious, and I screen her, and she is experiencing abuse, but she does not want to report it. Kids are not witnessing it. She's not being threatened with a lethal weapon. She's not asking for treatment for injury. That's not reportable. I don't have to call the police. I may encourage her. I may say, look, I think this would be helpful. Do you want me to help you with this? Do you want me to report? But I don't have to. And if she does not want to, I would not report that. I would help try to connect her to advocates. Here's the numbers for the child abuse, neglect, and vulnerable adult. So as I said, this is my photo of me spending a year trying to get comfortable screening for a problem I'm not going to fix. This is how it feels. So I just want people to know that from the front. If I think social workers are much better at this, sometimes internists and family medicine docs are better because they deal with more chronic conditions, and so they're used to working over time. But just getting used to the idea that it's really not our job to fix this. We're just trying to identify it and understand where the resources are and help improve education around the issue. And really, what we need is this coordinated response. There's so many people in the community that need to be involved. Our law enforcement has done some amazing work with the lethality assessment and improving the care of intimate partner violence victims. Our faith-based leaders really need more education and empowerment around this issue. They can be really powerful advocates. The media, our legislators, we are just one part of this, one small piece of it, and we shouldn't be expected to solve it or fix it, but we do need to do our part. And I feel like there's a lot more that we can do within the healthcare system to help patients affected by this. And so I just wanted to, this is my little tree of getting to the root of problems. I have a patient scenario I was just going to let you know about. Of course, I change enough so that the patient can't be identified, but just an example of how this might look. You know, I had a patient who was 30 years old, pregnant with her second baby, and she was 35 weeks. And my partner called, and it was probably 6 o'clock at night. And she said, oh, I got this patient. She always comes in. She's going to have 30 minutes of questions. There's always something wrong, but I can never find anything. And she's coming to labor and delivery. She thinks she may be in preterm labor. I'm just telling you, you need to be there. You need to talk to her because it's going to take forever, but there's probably nothing going on with her. And so I said, okay, that's fine. You know, I'll take care of her. So she sent her in, and she came in through triage and labor and delivery. And her review of systems was positive for everything. Anything you asked her, she was like, yeah, I think my water might be broken. I might be contracting. My muscles ache. I might have a fever. I'm kind of nauseous. Yeah, I have a little diarrhea. It was like, oh my gosh, what's going on with this lady? But everything, her vital signs were fine. Her baby looked great. She wasn't in labor. So there was nothing emergent happening. And her husband was there with her, really nice guy, seemed totally supportive. So we kind of went through everything, ruled out anything crazy. And then I spoke with her alone. And I said, you know, one in four women, I had her partner wait in the waiting room. And I said, 1 in 4 women are in super unhealthy relationships at some point in their lives. Has this ever been a problem for you? And I thought for sure she was going to say no. And she, just the look in her eye she gave me, everything just stopped and was quiet. And she just stared at me. I mean, it made the hair on my arm just stand straight up. She looked at the door. She looked back. She looked at the door. She was fearful. She was scared about, where is he? Can he hear this conversation? I was like, okay, here. Something's going on here. It turns out this was her second pregnancy. She was experiencing definitely emotional, verbal, psychological abuse from him. And the thing that scared, it hadn't become physical this pregnancy. The thing that scared her so much is her last pregnancy a few years ago, it was physical. It had become very physical back then. And so she was so scared and so on edge that it was going to become violent again. And I said, look, I could tell she was worried about him coming back in. I said, if he comes back in, we're talking about something else. Like, we're cool. You're fine. I'll cover you on this, you know? And I sent the nurse out to make sure that he wasn't standing by the door. And he owned a lot of firearms. And so she was really worried. She denied anything reportable, but she was really worried about threats with weapons and what he was capable of doing. And so I was able to identify it. I was able to let her know that this is impacting your health. And this is all within 5-minute conversation with her. I was able to give her the link line, and I came up with a plan. I said, look, anytime you have an issue, you have a urinary tract infection, okay? Call me. You have burning when you pee, you have blood in your urine, we'll get you in. Like, we have a code word so that you can get in and get an appointment. And then I just briefly talked to her about journaling and keeping data, time, you know, tracking a calendar somewhere that he can't see, where dates, times, events that happen. Making sure that she knew that removing a cell phone is a felony. So if she's ever calling for help, and if a partner destroys a cell phone or takes your cell phone, throws it across the room, that's actually a felony, because you're using that to call for help. And then I talked to her about strangulation. Like, if he ever does these things, you know, you're in serious danger. And that if there's a firearm in the home, you're way more likely to have problems too. So thinking about ways, you know, is there any way you could have relatives hold the firearm in a different location? And it was just 5 minutes. And sure enough, he walked back in. He wouldn't wait until I came out to get him. He kind of barged back in and was like, what's going on? And I let him know, look, I've been talking about, you know, when I had my second kid, sorry, I'm just blabbing here about when I was pregnant with my second child and how hard it was. And it's just physically so exhausting when you have another kid. I just kind of went on and on about how I was talking about myself, and he was totally fine. But I saw her for multiple visits later on where she called with UTI symptoms, and we were able to talk, line things up, get her with an advocate, and do safety planning. And she did not leave right away. She left probably a year later, but she was in touch with advocates that whole time. And that was 5 minutes. So it even shocked me. I wasn't expecting that to happen, but that's kind of how it can look. And if you look at what Bridget McCaw did at Kaiser, she was persistent. So she worked for a long time at Kaiser, but look what she did in adult medicine and OBGYN, the number of patients that were identified and connected to resource who were experiencing IPV. It's pretty impressive. And again, the ED, ED is kind of like labor and delivery. It's not an ideal time. They see a lot of IPV, but it's not always the ideal time to have conversations about it in a chaotic, emotional setting. So there is an equality wheel. So I like to post that as well, what that healthy relationship looks like. There are definitely evidence-based, data-driven programs that have been shown to prevent intimate partner violence, and this is one of them. So, and like, why we wouldn't do this across our state more and expand these type of programs, I don't know, because I think there's such opportunity there. And we're really never going to get anywhere unless we have allies from all angles. And I think having men who support really healthy consensual relationships is so critical to this work. And Coaching Boys into Men is an amazing program that's already completely set up. So if you know any men who coach football or basketball or, you know, any sport, have them check this out and see if they're willing to incorporate it into their programs. I have some TED Talks that are not too long, that are really interesting. So if you're interested in this topic, I highly recommend you check these out. And there's a little video from Kaiser Family Violence Prevention Program at the work that they're doing. And these are the two books that survivors have told me over and over, you got to check out these books, that I read years ago that really helped me understand how to speak with victims of violence and survivors. And so I highly recommend these, but I'm always looking for suggestions. And like I said, this is definitely a work in progress at Intermountain Healthcare. We're sort of rolling out screening for IPV, and we're open to suggestions, and especially from survivors. I feel like the best advice that I've gotten has been from people who've been through this and tell us what they want to see out of their healthcare systems, what's going well, what's not going well. So I'd love to hear your comments, questions, but that's my talk.
Wow, very powerful. Thank you so much. Thank you for sharing that story about your patient. We sincerely appreciate all that you are doing to help these women. There are a few questions in the chat. There's just a clarification on the reporting requirements, and we know it's state specific. Could you just clarify in Utah specifically what are the requirements for reporting? And I think you may have even had that on a slide.
Yeah, there should be a slide on it, but child abuse is required. So any minor experiencing this for sure. Vulnerable adults are required to report there. And then specifically threats with a lethal weapon. So somebody has a gun. Strangulation now, I would argue, is a threat with a lethal weapon, because people can be killed so quickly through strangulation. I would consider that reportable. Children witnessing or experiencing violence is reportable as well. And assault, a patient coming to a healthcare for treatment of assaultive injury. So there's, she's pushed down the stairs, she cut herself, I'm sewing her up, and she says, this person did that to me, that is reportable.
Thank you for clarifying those. There's also a question about how can we encourage women to come for care when often they're more interested in protecting their partner or abuser rather than caring for themselves?
Yeah, I was having a conversation with someone about this just the other day, how it's a lot of folks, and this is where that book, Why Does He Do That, is so helpful of getting into the mindset. So many people in abusive relationships will defend their partners, and they don't want other people talking badly about their abusive partner, which is an interesting and frustrating dynamic. But I find what survivors has said is most helpful is talking about this in the context of health. Instead of pointing fingers and blaming this person's doing this or that wrong, like if you're seeing these things in your relationship, it's probably affecting your sleep, your anxiety, your depression, your ability to take care of other things in your life. That makes sense. But if we start blaming and pointing fingers at who's a bad person, and most survivors just do not connect with that at all.
There's another question related to reporting, and they're just asking more about the process. So kind of what happens when you report, and does the state go after the perpetrator, thus revealing what the victim disclosed?
Yeah, I mean, this is one of those things where, again, not my area of expertise as far as the reporting for adult protective services. I don't know if we have anyone from adult protective services or DCFS or law enforcement that could chime in here. That would be great. But we just make the report, and then I know everybody is short-staffed. They're required to follow up on these things. But exactly what happens and what the time frame is, I can't speak to.
Thank you. Could you talk about, you had mentioned, whether it's a friend or a coworker. I mean, I personally have witnessed a neighbor that was probably going through intimate partner violence, and I just wasn't sure how to have that awkward conversation, or how to open that window so that you make them feel safe to disclose. So can you talk about that? Like if you know, I've seen people, for example, in the grocery store with a black eye, or, you know, what's the best way to kind of open those crucial conversations and provide that information?
You know, it's tricky because it's so specific to the situation, but I think just being there and believing people and listening to people is so critical. Not judging and not telling them what to do. So many people in relationships like this are completely controlled and told what to do and are demeaned. Their self-esteem is really crushed, and they're constantly being told what to do and they have no choices. So to have someone who is just saying, I want to support you, I want to listen to you, I believe you, just that alone is very, very powerful. So I think the listening piece is probably the most important. And then at least knowing you have the UDVC link line. Like a lot of people are scared to approach this because they're like, I don't know what to do. I'm not an expert in this. I don't want to say the wrong thing, you know, but you have that link line. So we all have that thing where we can refer someone as needed. And I think shifting the conversation away from victim blaming and why aren't you leaving and why are you staying with this person who's beating you? Like, come on, and shifting it to that, you know, we want to support you. This is a healthcare issue. I'm worried about your health. I've seen a change. And I want to be here to support you. What's going on? You know, and I think if every healthcare provider is talking about this at every visit, I saw a patient just yesterday, and she moved back from Texas. I used to take care of her in the past when I didn't screen. She moved to Texas, had her babies there, and I went through my thing. She's like, wow, I've never been asked any of these questions. This is awesome. And it was a non-issue for her, but she goes, I'm so glad you're asking this. It just opens up the conversation so people do feel a little bit more comfortable talking about it.
Great. And also in the chat, someone was saying here, Terry was saying that just believing is paramount.
Yes.
Great. Well, I will open up the poll. If you guys can please provide us with feedback on this session. We will be sending out the slides and a recording of this. I want to sincerely thank all of the participants for being here and joining us, and especially to Audrey for sharing this wealth of information and really helping us to figure out how we can incorporate this into our practices. And I will open up the floor for any other questions. Any parting words, Audrey, again, that to kind of give people confidence to be able to have this discussion?
I'm just so happy to have had the time and glad to hear your comments and questions. And yeah, I would just say feel empowered now today to move this work forward, because we're not going to get anywhere unless we keep talking about it with each other, you know, in our community, and sort of pushing the envelope forward, and not just remembering that you don't have to be an expert in this issue to make a big difference in people's lives.
Great. Thank you so much. You're getting tons of kudos in the chat saying that your presentation is so resource rich and you are the best. So thank you again. And I hope everybody enjoys the rest of your afternoon. Thanks all.